A very good morning to everybody. A warm welcome. I thank the Clinical Club for giving us an opportunity to say few words in IVF. And yes, the magnitude of infertility is on rise. And so here we are going to present in a form of a case presentation. The success rate in IVF has been modest. Even after 25 years, the success remains as the 25 to 30% live birth rate per case initiated. That is, out of 100 cases, only 25 or 30 women would go home with a baby, and so the remaining comes under the repeated failures. So the newer strategies, newer innovations have come how to push these pregnancy rates. And we call them as multiple IVF failures or repeated IVF failures. It is defined as there are 3 IVF failures following transfer of 10 good quality embryos. Either you do it single time or twice, where there is a good response to the ovulation induction, good endometrial cavity, there was no endometrial development is good, embryos are good, and there is no pathology identified. And in spite of that, the woman doesn't become pregnant, she comes under IVF failures. And repeatedly, 3 failures and above, we call it as repeated IVF failures. Then I'm going to present it in the form of a case report, how we are dealing with these repeated failures. In September 2022, a couple 39 and 42 years came to the clinic, married for 8 years, presented with repeated IVF failures. The husband was normal, she was hypothyroid, diabetic. She gave a history and she was referred from a Kerala, a premier institute, for a further management. She gave a past history of having a laparoscopic myomectomy in 2017. That is, immediately after her marriage, she started her treatment, and followed by 2 cycles of oocyte retrieval, and 4 times she went through embryo transfer. It didn't conceive, so then she had to go through a hysteroscopic myomectomy in 2019, and then followed by 3 cycles of oocyte retrieval and 5 cycles of embryo transfer. And after the 3rd cycle, they have done what is called IRA to time the embryo transfer. In all this, 8 pregnancies, 8 times, she conceived twice, but it was a biochemical pregnancy, and as the husband was normal and she was a diabetic and a hypothyroid. Then we started evaluating her at our center, and so as usual, here was a patient with 8 failures and increased maternal age. She was 39, so she went through a routine evaluation like a master health checkup and the hormone evaluation, which was normal. Ultrasound showed again a recurrence of fibroids, because whenever we start the treatment, there is a rise in estrogens and the recurrence of smaller fibroids become enlarged. And it was a 5 centimeters lateral wall fibroid, and another one was close to the cavity, and multiple small fibroids. And then we assessed the endometrial cavity, and we showed a minimal distension. So we said you have to go in for a surgery, and prior to the surgery, it would be better we could freeze your embryos and start it. So the first time we went with the procedure, and the first cycle we treated her with a Recagon, this is the second cycle, with a Recagon injection, and we got about 10 oocytes, and 7 embryos were generated on day 3, and it was frozen. Following that, in the month of December, she went through the surgery, laparoscopic. And in the laparoscopic surgery, the cavity got inadvertently opened and the bed had to be sutured. Whenever the cavity is entered, we have to give them a 6 months of waiting time to heal the cavity, endometrium. So thus, we suggested go for 1 more cycle of IVF, because you are almost at the end of your reproductive career. So we'll collect some more oocytes and make the embryos and keep. The second cycle, again she went through, giving her with a gonalef injection. That's a good quality injections, and we got about 4 embryos generated out of 6 oocytes, and that was also frozen. Then what else to do next? So in April, we started her with doing a PRP infusion. Now, see, initially when the IVF came, And the PRP is the one which causes a local injury and improves makes the endometrium more receptive to the implantation. So twice the PRP was done, the platelet-rich plasma, and in May 2023 we did once more PRP, and 2 good quality blastocysts were transferred as per her ERA report, and it turned out to be negative. Then we did an ERA test and got a report saying that it should be transferred at 180 hours only. So normally we transfer the embryo at 120 hours from the time of progesterone starting or from the time of egg retrieval. But in her case, it was 180 hours, that is 7.5 days. That is almost 2 days later only her endometrium is going to be receptive. So in June 2023, we thought 5 embryos and got 2 blastocysts. They were transferred according to the ERA report, and she came, beta HCG was positive. She was treated with heparin. She had a very stormy pregnancy throughout, threatened miscarriage in the first trimester. Second trimester, she was diagnosed to have a short cervix, cerclage done. Her hypothyroid and diabetes was excellently managed by Dr. Suresh. And in February 26th, 2024, she delivered an alive female baby and a happy family. So now, initially when the IVF came and we are finding so many repeated failures, the newer innovations have been done to push these pregnancy rates. Yeah, so the first they started manipulating with the oocytes or the embryos. Now what they did with the embryo is that when you freeze the embryo, the zona becomes thickened. So they said we should do laser to make the holes or a drilling of the zona so that the hatching will take place. That did not improve the pregnancy rate. Then they said, okay, we'll take a single blastomere, do a chromosomal analysis and transfer only the good quality embryos. That also did not improve the pregnancy rate. Then they came out with embryoscope, where you fit in a camera into the incubator and every minute you see how the embryo is multiplying and only the best fast growing embryos to be transferred, but that also did not give any improvement. So then they moved on to the next one, that is the endometrium. And in the endometrium, they found that whenever you do a local scratch, a local injury like a scratch, or you insert a PRP, it would double the pregnancy rate by causing a local inflammation, immunological mechanism, and so in the following cycle, a normal endometrium will start growing, and that would improve the pregnancy rate in patients with repeated failures. And there have been a lot of studies done. Okay, I think there are a lot of slides have been missed over here. And so the next came the PRP. PRP is a platelet-rich plasma where you take the patient's blood, separate the platelets, and that is infused into the endometrium, or you can inject it in the subendometrium. That is just beneath the endometrium is been injected, so that will cause a local injury, inflammation, and there are a lot of studies. They have done almost, Cochrane also say, the Cochrane is the one which tells you it reviews all the RCTs, and almost it has gone through 1069 RCTs, and they said definitely PRP helps in patients with recurrent implantation failure. Then came the lot of RCTs, about 400 patients were used in each arm. The first arm got PRP, the second arm was placebo, and the pregnancy rate was almost 50% in the PRP group, and whereas it was 15% in the placebo group. Then comes the glue. Glue is nothing but a hyaluronidate, which when we load the embryos, this we have used it in her case, glue is a hyaluronidate which helps in implantation. It's a viscous material and viscous culture medium, and with that the embryo is loaded so that it can attach to the endometrium, invade and develop into pregnancy. And the third thing that came is the ERA test. ERA test is called endometrial receptive array test, where you prepare the endometrium as though you are going to do an embryo transfer, and on the day when you are planning, take an endometrium biopsy, send it for a genetic analysis, and that's the time they'll find out how many genes are there to cause the implantation, and according to that they will tell. In this case, there was a very short implantation, that is, patients with repeated failures will have a very short implantation period, and they have a thing. So in her case, it was 180 hours. So that's how the ERA will help. Because most of the time, when you replace an embryo into the uterus, there is a crosstalk between the embryo and the endometrium. And if the timing is not correct, then the implantation does not happen. So in her case, it was the fibroids, it was the shortened implantation that caused. And this is one of the such cases that I have told about, but there are so many patients who are there who have not got conceived, and they are still in that phase of failures, repeated failures. So patients with repeated failures have got short, and which can be identified with the repeated test, and in the majority of cases, we are not able to find the cause for the reason for the failures. Thank you.
First, I have to thank Dr. Lovinathan and MSO for consistently doing this clinical club meeting, because earlier when the clinical club was happening, we didn't see so much of crowd. And we're very happy that everybody is here on full attendance in the morning. Thanks a lot for that first. What the topic today we are going to talk is recent advances and trends in IVF treatment. What we should know about infertility treatment is the whole medicine itself will go generations and generations back. But considering IVF, it is only hardly 48 years old. The first IVF baby which was born, she was born only by 1976. Hardly she is 48 years old. The whole process of IVF just began in 1976. The first baby was in 1976. So the whole medical field of fertility is only 48 years old. Out of which from 1976 to 1990, there was no much of differences at all. They were doing the same process again and again. Then in 1990, they started all the newer interventions, and they started trying from 1990 till 2020. So hardly it is 15 to 20 years old. The first thing what you have to understand is the advances, whatever is happening is very, very new in IVF. Still we are exploring, still we are doing a lot of things inside that so that we could master the nature, because pregnancy is a nature, it is not a disease. So trying to master the disease is very easy compared to nature. So we are exploring a lot into it. First, to understand what IVF is, actually in our medical college, we see all the organs in anatomy except for oocyte and the sperm. I think no doctors would have seen oocyte or sperm in the college. They won't show it in the microscope. We would have seen all the bacteria and everything under the microscope, parasites, everything under the microscope, but not the gametes. So this is how the oocyte will look. This, how does it look is, this is a oocyte. This is a mature M2 oocyte. This oocyte is ready for fertilization. This is what is inside the follicle, which will get ovulated, and this will absorb the sperm to have an embryo. So this round thing is the center part. The outer one is the cumulus cells, and the black one which is around this is called the zona. Whatever madam was mentioning, the zona thickening everything. So this is a zona which is surrounding the oocyte. And what you see here is the first polar body. This is how exactly the oocyte will look when we aspirate it from the follicle. And this is a little more magnification image of the oocyte. How does it look again? This whatever that you see inside is the nucleus. This nucleus will take the sperm inside, and this will create an embryo, and then we are all here. But compared to this oocyte, if you consider the sperm, this is how the sperm looks exactly under the microscope. It has a head, it has a neck, it has a tail, and it is comparatively much smaller than a oocyte, mature oocyte. That's how the nature has done. And then the oocyte will be hardly a single oocyte for a cycle, and sperms will be multiple and millions. So this is how the exact gamete will look. An egg and a sperm will be under this way under the microscope. So what they were doing earlier, we were doing two procedures. One is IVF, which is called in vitro fertilization. The second one is called ICSI, that is intracytoplasmic sperm injection, and this is called IVF. So what we did in IVF is, we take the oocytes from the women's body, we put it in the petri dish, and this is a oocyte here, and we load it with many sperms around the oocyte. And this nature will decide which sperm to get inside the oocyte. So it's a decision of the sperm to enter the oocyte and make an embryo. And then once this embryo is formed inside the petri dish, we transfer it inside the uterus of the woman and she gets pregnant. And the next advancement what had happened was ICSI. So what was ICSI is, we will catch the oocyte. We will keep the oocyte with a pipette. We'll hold it in a pipette like this, and then through this needle we take a sperm and inject inside the oocyte. So this is done under a microscope by an embryologist. So these were the two procedures which was happening. One is IVF, the other one is ICSI. Whatever we say IVF department is just a common term to understand for the public, but actually IVF is the name of the procedure which is happening. So IVF is which will help in the natural selection, and this one is done only by an embryologist. So how does we actually do? So this is a petri dish actually, and this is how we load a droplet. Inside this droplet is the oocyte, and then with this we hold the oocyte, and with this needle we take the sperm and inject inside this. So under a magnification, if you put a microscope on this and take a picture, so this will look like this. So this is a oocyte holding pipette, and this is a needle, and you can't see actually there is a sperm inside. This will go inside through this way here, and the sperm will be dropped inside the oocyte. This is called the ICSI procedure. And then the beautiful embryo forms. Day 1, day 2, day 3, day 4 and day 5. 5 days it is cultured inside the incubator. And this is a beautiful blastocyst. What we get, it's called blastocyst. It's a day 5 embryo. Once this embryo is formed, this whatever you see here, the round thing is called the inner cell mass, and this inner cell mass will come through this layer outside, and then the pregnancy happens and the fetus implants inside the uterus. And to achieve this blastocyst is very, very important in an IVF or ICSI procedures. So what are the advances to make all this? This is our nature which is happening. So there will be a oocyte, there will be a sperm, it will fertilize, it will make a blastocyst, it will hatch and it will implant and it will grow. So what we are going to do? So there are a lot of advances in this. The first thing is regenerative medicine. Regenerative biomedicine has been in all fields, particularly like orthopedics, dermat, we all have heard the stem cell treatment, PRP treatment and all that stuff. Everything is coming into the reproductive system also. What stem cell treatment, why the stem cell is very important in reproductive medicine is, it has the ability to differentiate into any cell and repair damaged cell and then regenerate the cells. So this regenerative biomedicine is occupied completely of the reproductive system. So how do we use? Where all we use? The case what madam presented was in recurrent implantation failure. It could be in the endometrial problem or it can be in the ovarian problem. So even in impending ovarian failure, if the ovary is not functioning normal for a girl, we can use this PRP, which is platelet-rich plasma inside the ovary, to make the ovary regenerate and help to give a good oocytes. The second one is an implantation failure, where the uterus is not okay to implant that blastocyst. So then we can make that endometrium better with PRP infusions. And third thing, as sir mentioned about Asherman's, this Asherman's is something, there will be adhesions inside the uterus, making the endometrium very thin. So in all these three conditions, we can use the PRP. But of course, PRP is not completely evidence-based, but only few cases like 500 or 1000, maximum 2000 cases they would have done everywhere. That is a case report. With that, but we were able to do, they were able to give some pregnancy rates of 40 to 50%. Even that is a very good number. So we have done a lot of PRP. Both ovary as well as endometrium, we have done many PRP in our center. How it is actually done is the same way. We take the blood of the patient and then centrifuge it, concentrate platelets 6 times more than the natural values in pure plasma without red cells. What is the idea is, all this when you centrifuge, it will release a lot of growth factors. That growth factors will help in the regeneration either in the ovary or in the endometrium. Same concept as we use it for skin or hair. We inject for the skin for regeneration, we inject for the scalp for getting more hair growth. The same concept we use it for ovary and endometrium also. So it helps in endometrial regeneration as well as the ovarian regeneration. But this endometrium, how do we infuse this PRP matters. There is 2 ways of infusion. This all we are doing it currently. This was not earlier. So just take this PRP solution, prepare it, load it in a small catheter, just put it in the endometrium as an OP procedure. The second one is take them to the theatre, do a hysteroscopy, see the entire cavity and infuse with the needle. You inject with the needle at all areas of the fundus so that it helps in implantation. So these are the 2, non-invasive and invasive for endometrium. And considering ovary, how do? We can do transvaginal as well as through a laparoscopy. Just put a transvaginal probe, put a needle, reach the ovary, and then infuse a PRP inside the ovary on both the ovaries. Or else do a laparoscopy and then visualize the ovary under the camera with a visual identification. Inject the PRP inside the ovaries. These are the two ways of doing an ovarian PRP as well as an endometrial PRP. And this PRP earlier they were just putting inside the uterus. From there we have moved so much into the PRP installation through an invasive procedure, through visualization, which makes a good results, which is giving us a very good results in PRP. And the second advance what has happened is mitochondrial replacement therapy. It is an interesting thing in mitochondrial replacement therapy because what we do is we take the mitochondria. We know this mitochondria is a powerhouse. So this we take the mitochondria from a donor girl, and then take that mitochondria. Where will be the mitochondria? It will be in the cytoplasm, not in the nucleus. So we saw the oocyte, isn't it? There was a nucleus, there was cytoplasm. So take the mitochondria from we can't exactly take the mitochondria, but the cytoplasm is drawn from a donor egg, and that cytoplasm is transferred inside the our own patient's oocyte, so that her cytoplasm has the mitochondria from the donor cytoplasm. So that will help in the improved fertilization of her own oocyte with her husband's sperm. That will give a proper result and a good embryo. So what is this is called as 3-parent technique, because we take the cytoplasm from the donor and we use it in her own oocyte with her husband egg. So it's called 3-parent technique. But the importance, there is a little ethical consideration, but she can't be the mother. Donor is not the mother here. She can't be the biological mother. So the biological parents are the same patient as well as the husband, but to increase the success rate, we take only the cytoplasm of the donor. And it had a good success rate, but because of this little bit of 3-parent technique, still it is under hold. It has not come into completely into all system of IVF in our country. Still we haven't started it, but we are ready to start this mitochondrial replacement therapy. And third thing is endometrial receptivity array. The previous patient what madam presented, should be, we were proud to say, she should be the first patient of the whole world having 180 hours, after 180 hours of transfer and achieving a pregnancy. And madam did ERA for her. So what is endometrial receptivity array is the same way we have to know the window of implantation of the endometrium when it is going to implant. The nature what it has done is, oocyte has a lifespan of 18 hours. Sperm has a lifespan of only 48 to 72 hours. Same way, the window of implantation is only 24 hours. The endometrium will be receptive for an embryo only for 24 hours for the whole month. So the technique of IVF of any fertility treatment is to identify that particular 24 hours. So there were a lot of techniques to understand which is the 24 hours to make ourselves transfer that blastocyst inside the uterus. So to aid that procedure is this endometrial receptive array. So what we will do is, we will prepare the endometrium as if you are going to transfer an embryo, and then when we decide to transfer the embryo, we don't transfer the embryo. We take the tissue and then we send it for we send it for molecular analysis. Then the report comes to us, yes, you can transfer exactly at this hour so that you will get an implantation. That's how we plan it, and then we implant. And doing this, this is a molecular tube, but the cost is around 30,000. But initially it was like 60 to 70,000. So we weren't able to give all patients this facility. Now they have slashed the price to 30,000. So we are doing lot number of ERAs, and we are getting more number of pregnancies doing this ERA test. So this is how the report will come. This ERA test, it will give us receptor. This is a receptor, and here this is not very clear, but they will give exact hours. What they have given is 120 plus or minus 3 hours of progesterone administration. So what we will give is, we will give progesterone, because progesterone is needed for implantation. We will give progesterone exactly, we will do 120 plus or minus 3 hours, and she became positive. This patient became positive again. So exactly on the time when we transfer, almost 80 to 90% we are able to get the results. And this has been done repeatedly in our center too. And then comes pre-implantation genetic testing. This PGT, pre-implantation genetic testing, is a procedure. What we do is, we screen the embryos for genetic diseases. We can do it for two things. One is PGT-A, PGT-M. That is, A is aneuploidy for chromosomal disorders, M is monogenic for single gene disorders. If a family carries a particular disease, we can always screen the embryo, take one blastomere, just to go back. So this is a blastocyst. What we do is, we take one cell from here. This is called blastomere. We take this, pull out this cell and then send it for molecular analysis and check the chromosome of this particular embryo. So this chromosome will be giving the monogenic diseases if they carry in the family, or screen for any particular diseases which has been carrying in the family, or if the parents are carriers and they are worried whether the children, when their baby is going to carry the same gene or something like that, we can always test for that particular thing. This is what being promoted in all other IVF centers. They take this blastomere and check the sex of the embryo, like whether it is XX or XY, and then transfer only the XY to get a male child or XX to get a female child. But this is completely illegal in India and nobody can do it, and it is punishable. It is legally offensive. So no centers are doing except for promotion, but nobody can do because no consent, it's not legalized in India. But we do it here only for checking the chromosomal disorders, aneuploidies, and then monogenic disorders. So this is what is about pre-implantation genetic testing. And what is the other new innovation? This one we are doing here. So why we are specifying all these advances, and then I'm mentioning that we are doing it here is all the advances which has been coming into the IVF procedures. It is happening in Ramakrishna also, but it is many patients are benefited with PGT. And then comes laser assisted hatching. Like what we use as a laser pointer. So we use a laser pointer here. The same way there is a small laser machine which is attached to the microscope, and that will emit this laser point. So this laser point will go and touch the blastocyst, what we saw, and then it will just make a hole on the blastocyst membrane so that it can hatch. The inner cell mass can hatch very easily through that hole, just breaking the surface. So it can hatch very easily so that it will aid in implantation. That's called laser assisted hatching. It's a small hole which is made in an embryo. Particularly to whom we have to offer this laser is advanced maternal age, that's more than 35 years. Of late we see very hardened zona even after 30 years. So whenever we see a hardened zona or the embryo is unable to crack itself to hatch, we use this laser shots. And this laser assisted hatching has still have increased its success rate. What is the next is embryoscope. Embryoscope is a time-lapse imaging. It assesses whatever is happening inside the incubator. It just gives like a complete picture of an embryo, however embryo is going to become from a gamete to a complete embryo. So it just gives a repeated shots, multiple shots is taken inside the incubator. Actually, how does it look is exactly this is the machine it looks. And then this is a machine. And this is how this embryo pictures come. I can make it a little more clear. This is how it looks. So how does it have? See, this is a oocyte. This oocyte has already has the sperm inside here. Then it's fertilizing. It's becoming 2 cell, becoming 4 cell, becoming 8 cell. This is all like first, second, 3, 4, 5. So this is a morula, which is the 4th day, and this comes a blastocyst. And this blastocyst which hatch, and then it will make a pregnancy. So this is like static pictures, but embryoscope will give a moving time-lapse technique. It just gives a moving embryo. So we're considering 10 embryos. We can just take 10 embryos and see which embryo is fast growing, which is slow growing, which has little bit of slowness in that. Depending on that, we can select the embryo to transfer inside the uterus. And it is helping little more, and the prices also has slashed. So we are ready to get this embryoscope, but we are going to get this soon. So this all whatever discussion was happening was for female infertility, ovary, endometrium, embryo, and this embryo implantation and all that. So even a lot of advances happening in male infertility. So considering male factor, earlier it was only female factor which will lead to infertility problems. All male were normal. That was the dictum everybody had. But of late last 10 years, we see lot of gamete problems. We didn't know. Even in my practice, I can say 15 to 18 years of my practice, Initially, we didn't see much of gamete problems for sperm at all. But last 5 to 7 years, no sperm is normal. There is a lot of abnormality in the sperms. It's really pathetic to tell a boy, even at 25 years, to tell them that their sperms are not normal. So we have to consider doing all the lifestyle changes, as well as no smoking, no alcohol, no weed, and proper no obesity for them to have a good gamete. But what we are helping them to do is, the first advance came as home sperm analyzer. Unlike giving a blood sample for for any investigation, doing an ultrasound for a female, it is very uncomfortable for a boy to come and give a sperm, collect it, and then give it to a staff over there, because there is no male staffs, only the female staffs are there. So they will have to collect it, hand over his semen sample. For the wait for the semen sample, it is really uncomfortable. The first advance is what it has been made is home sperm analyzer, so that it has been connected to the smartphone. So he has his own basic system of doing it and at home itself, for them to have a confidence. If there is any abnormality, they can reach the hospital very early. So this is the newer one which has come. It's called, the name is Yo. It is home sperm analyzer. It is available in the market. They can just connect it to the. They have to collect it. They have loaded in a smaller like a slide or something, and then put it inside and connect it to the smartphone. It gives a report. At least basic count and the movement of the sperm is given by the home sperm analyzer. And then comes the actual problem. If they have they're doing a home sperm test. If they have an oligospermia or a azoospermia, earlier what we were doing is we were just giving them antioxidants. Then I suggest them procedure of doing an intrauterine insemination, which is called IUI. This IUI, we take the semen sample, wash it, remove all the fluid, only the sperms are concentrated. These sperms are transferred inside the uterus. This is called IUI. Only these two procedures were done. There was no much of counseling or anything was happening to a male. But what the recent one we are doing is, we are doing Y chromosome microdeletion by multiplex PCR to amplify smaller genes in the Y chromosome. Why that boy has an azoospermia? It could be a pathological problem. Pathological problem can be corrected. Apart from pathological problem, why he should have a severe oligospermia or azoospermia? There will be a chromosomal problem. Initially, we were doing only karyotype. What is karyotype? It is only 46XY. And if there is any translocations in that chromosome only, it will be detected. And it is not going to help us anyway to counsel them. But this Y chromosome microdeletion, taking the Y chromosome XY, they will carry XY. Take the Y, it has 3 parts, and then do that Y chromosome microdeletion genes, and then can counsel them proper. The one thing is, it is not rectifiable. This test, what we have done, we are doing it as an advanced treatment for male infertility. It is not rectifiable, but this can give us a proper source of counseling, because when they have lot of microdeletions or they have any problem in their chromosomes, they are going to transmit that chromosome to their next generation, if that is a boy. And if that boy is going to grow after like 30-40 years, he may turn infertile. Then that process keeps on growing. So we have to try to put a stand there, and we have to try to counsel them, because even they want their own child in their own gene, but still we have to counsel on this problem, that this is going to be carried in their male child. But this one we are off late, we are doing it. Of course, PRP has its role even in male factor. And this one is injected inside the testicles, which will help them to recover the sperms even in an azoospermic individual. And PRP, injection of the testicles, is done under an OP procedure itself. It is absolutely a painless one. And considering this male factor, the main thing is, we have to identify the best sperm to give a good embryo. That is the only thing. So all advances which was happening for a male factor infertility, for a male factor problem, is to identify a particular, because a million of sperms, all the sperms will be moving. Every sperm will have a head, neck and a tail. But how to choose a particular sperm to inject inside that beautiful oocyte to get an embryo. So all the techniques were improved only to identify a particular good sperm. So the one technique which is this microfluidics. What is microfluid? Initially, how we will take a sperm is, we'll just centrifuge it. Then all the dead sperms will come on the top. We'll remove all that. Whichever is concentrated below is the good sperm. We'll take that sperm and inject. Normal potential will swim itself and then reach a particular area. If it has that capacity to reach particular area, that can form a good embryo. So that is what the idea of doing this microfluidics channel. So how does it actually work? So here, hardly 3 more slides. Okay, we'll load the semen here, and this semen will have the sperms, and this channel will be like this. The sperms will keep moving, and here there is a culture media which is giving a protein to that sperm. This media will mix with the semen, and then once it reaches here, the sperm, which has a very good capacity, just goes up. It just swims there and reaches this media. The sperm which is not motile or not very good, it just reaches this media. So we'll try to take these sperms and then put it under the microscope to do an ICSI procedure. This is one way of getting a good sperm so that we have a good success rate in ICSI. So how does it actually, this channel will look? This is the channel that it looks. Okay, everything is small plastic containers. This is one. So we load it here, the sperm will go through this, the media will come through this, the sperm which reaches here is discarded, which reaches here is taken, and then it is used for the further procedures. So this is one way of identifying a good sperm. And then comes if there is very minimal sperm. Okay, there is no sperm, maybe no sperm at all in the semen. We have to take the sperms from the testis. That's called testicular biopsy. How do we do a testicular biopsy? Is open the testis, take a small tissue, put it under the microscope, see that small tiny head, neck and tail sperm, take it and then use it for the procedure. But sometimes we may not identify multiple sperms even in a testicular biopsy. Then comes micro TC. So what is micro TC is? Doing a testicular sperm extraction, that is what TC is, the testicular sperm extraction under a microscope. So how does it done? It is done this way, and there are like couple of patients we have started doing it here too. So under the microscope, then they will operate, they will identify the high probable zones of seminiferous tubules under the microscope itself, and then they'll pick the sperm. But when we do a micro TC, we will be getting hardly 1 or 2 sperms. Only it is done only for those patients who don't have sperms. We do a conventional procedure. So hardly like this we will be getting. We'll be getting only, this is 1 sperm, this is 1 sperm. Hardly 1 or 2 sperms on the entire testicle. Use a microscope, they will be screening the whole testis for about 3 to 4 hours to pick only 1 or 2 sperms. So how then it is our responsibility to store this sperm, use it proper for the ICSI procedure. So the newer technique is, this is called sperm VD. The sperm VD which is used for micro TC. So when we do a micro TC and give 1 or 2 sperm for the embryologist, it is her responsibility to store that single 1 or 2 sperms properly and then use it for a ICSI procedure. Because on the same day, when we are doing a micro TC for the husband, maybe the patient would have not been ready. Her oocytes wouldn't have been ready. So we would have planned an IVF procedure for her the next month. So we have to store these 2 sperms for till the next month. So what we do is we do the sperm VD. Sperm VD is a small device. How does it look like? This is a device. This is a small device again. They load 1 sperm here, the other sperm here, if you get the third one here, and then dip it in the liquid nitrogen immediately. That is called vitrification process, so that it freezes there on the exact same day. The same sperm will be frozen in these 3 smaller ones. That can be used for the future procedure. And this slide is particularly was given by our embryologist. She's not here, she's out of country now. So then came this vitrification. This vitrification is quite old, maybe 5 to 6 years. Vitrification is a process of freezing the embryos. Earlier it was slow freezing. Even when we started in Ramakrishna, it was slow freezing. We take the liquid nitrogen, pour it over the embryo and then keep it for 10 minutes. Again, pour the liquid nitrogen. It will take about half an hour to 1 hour to freeze the embryos and the oocyte or the sperm. Now the procedure what we do is vitrification, which is rapid freezing. Take the embryo, dip it in the liquid nitrogen. There are devices, vitrification devices with small sticks, it will be like small sticks. We load the embryo on the tip, put it in the liquid nitrogen. It just freezes then and there, which can be stored even for 10 years. So it is done for oocyte, embryo, ovarian tissue, sperm. And then of late we are doing social freezing. What is social freezing is, even an unmarried girl, if they are going to give her oocytes for the future use, they can use that vitrification procedure for social freezing. Then the recent one is automation. We are all talking about automation, robotics and artificial intelligence, and even this is coming into the IVF lab, where IVF lab is on a chip concept, avoiding all manual handling, and embryologists can be minimized and it's too automated using robotics. And then this artificial intelligence also is going to help us, because it screens all the details, all the details. Database is going to give the complete database, so that it's going to help us in the future how to achieve the proper success rate. And the last slide, this one everybody has to concentrate at least for a minute. This is the ethical advances. See, like Shah Rukh Khan, like Nayanthara, who all have gone into surrogacy, even though they had oocytes or sperms, they have done the surrogacy. Indian government has made it mandatory to put and stand, and they have made a law last year, and this law is in the Gazette now. No alteration can be made in this. So what are the real ethical things that can be happening in IVF is, the first is social freezing. Even an unmarried girl who's going for college or a married girl, if they want to delay their pregnancy for the future, they're getting married by 22, they want their pregnancy at 35, they can come, take their oocytes, we stimulate them, take the oocytes, freeze the oocytes through vitrification process, and that can be used for the future use. First is social. Second one, no treatment after 50 years for women and 55 for men. We have heard like 60 years grandmother delivering, 65 years grandmother delivering triplets and all that stuff. No. So 50 for women and 55 for men. And then third one, no commercial surrogacy. It is only altruistic. Altruistic is only relative. The patient has to bring her own relative only for surrogacy, and they can't be commercial surrogacy. This all came up only after Nayanthara did, because Nayanthara got two boys through a surrogacy, and it should be no money should be transacted. So no commercial surrogacy. Fourth one, donor program. Donor can be oocyte donor, sperm donor. Both donation is legal in India. In certain countries, they can't do donor oocyte program, but in India, oocyte as well as sperm donation is legal. And the fifth was single women. If she's a single, because in the future we are going to have all these counseling problems. They're going to come as single. Why do you want to get married? But I just want to have a baby. So single mothers or unmarried women can avail IVF through sperm donor. But single man cannot avail surrogacy as Karan Joga, because Karan Joga was trying to have a baby. So single man hereafter they can't avail a baby through surrogacy, but single woman, she has all the rights to come and have a single mother or unmarried girl can come and avail IVF and then get a baby. And then surrogacy is done under only medical as well as judicial clearance. Through the JD office, they have to get a clearance, and then the court also has to give the clearance. Earlier it wasn't like that. So with all these procedures only, we can go ahead with the surrogacy program. And who should be a donor oocyte? Even before 2 years, college girls would come to us, and these girls will come in, they want for a pocket money. It was not happening much in Coimbatore, but it was happening in Chennai, Bombay and all metro cities. These college girls will come and give the oocytes, and they'll get 20,000 or 30,000 as a pocket money. But that cannot happen hereafter. So donor should be donor oocytes, okay, oocyte donor. Oocyte donor should be married with a baby of 3 years, and only once in a lifetime she can be a donor. They can't come and keep on giving oocytes for money. A single girl cannot come and keep giving oocytes for the lifetime. Only once in a lifetime she can give. And single man can be a sperm donor. He can be married, unmarried, anybody, doesn't matter. But for a donor egg, she should be married and have a children. But for a man, it doesn't. That is a relaxation what they have given for a boy. Anyone can become a sperm donor. And gay and lesbians, lesbian and transgender, no surrogacy. That is, it is only biological. If a lesbian couple comes to us, one girl, whoever is a girl, he or she has to be the carrier. Okay, the other one who's behaving like a man should be her husband. So there should be biological oocyte from one of the couple. These lesbians cannot come and ask for surrogacy within another girl. That's not possible in India. And in transgender also it is not available, and even gay it is not available. So there should be one biological parent. A gay cannot have their own child. They cannot go and avail a surrogacy. Gay cannot do it. And then NRIs. Then a lot of NRIs, non-residential people as well as foreigners were coming into India and having done their IVF here, but not anymore. Only Indian citizens will have the surrogacy program. No other surrogacy program can be done for foreign nationals. So this is it's a very good ethical thing what they have brought in government, but it is not benefiting many people, because many people they are like helpless, and that is where there is a little bit of gray area. But still, this is what we have to understand, and we cannot encourage, because we see at even 50 years couple coming and asking us for planning their pregnancy, getting married at 45, 46, and they come for 49 years to have a child. So we have to just inform this to whoever we know close by, so that these are we cannot overcome all these rules. We have to abide by these rules hereafter. And always we're looking for a future. We're saying then all these reasons, all the newer advances, it's ultimately getting a baby. When a couple delivers, we see the complete transformation. Immense happiness happens inside our ward also. So thanks for patient listening.
Thank you, madam. Any questions? Yeah, you have questions. So you started saying that you are assisting nature.
Yes. Good morning, sir.
And also Lakshmi. I have only a basic question. When you freeze sperm and oocyte, how long can be in a frozen state?
So 10 years, sir. 10 years, that's what they say. But we have successes after even for 5 to 6 years. We haven't exceeded beyond 10 years. But we had pregnancies like after 6 years, the same couple who froze with us 7 years back, they've come and then transferred the same embryos again. And the embryos which was frozen at her 32 years of age, they've delivered at 37. They will be born as siblings, like brother and sister, but the embryos are of the same set which was created 7 years back. And we had pregnancies. Even madam had a lot of pregnancies. Even I had 2-3 pregnancies which is going on. So it's good, sir, actually. But we haven't crossed 10-12 years. But it is good even for 10 years. That's what we see.
Okay, thank you.
Yes, sir.
What is the turnaround time for the ERA?
ERA, it's a month. So first month when we do it, they'll give us a
No,
result.
you will take a tissue, send it to your weight. What is the turnaround?
Within a week. Yeah, within a week, 10 days. So that cycle we won't be able to transfer. So within a week or 10 days, he will tell us this is how we have to do it for the next month. Then again, we have to mimic the same thing for the next month. Go through the same tablet, scan and everything, and then give it and then put the embryo on that day. Yes, Vidya. Yes.
First about the mitochondrial replacement therapy. So we are taking the donor cytoplasm and injecting into the oocyte. So is the oocyte not prone to rupture when doing that?
Yeah, that is a technical thing. So all the embryological work is mainly the technical thing. So it has to be very, very gentle. As we have started doing all these ICSI procedures, I think it won't be a problem for a trained embryologist to drop in. It won't be an issue.
So my second question is about the EGA.
Yes.
So can it be done as a routine IVF testing?
Yeah, we can do. Yeah, we can do. The only thing is that counseling the patient even for that 1,75,000 is really tough. It's really tough. And adding that 30,000 extra burden on her, no, it makes. So at the first visit, it is very difficult even to convince them. And almost not all ERA is going to help us. That is where it is. And if without ERA only, we have got a lot of pregnancies. So we can always try for a first cycle if the patient profile demands. If she had repeated failures earlier, she has gone through a lot of treatment outside and it is not the first visit to us, definitely we can suggest. The price is very affordable. 30,000, I think they can bear it again.
The patient requests before.
Definitely. Definitely we can plan it.
And my third question is, what if the sperm taken in the micro-TC is immortal? So because we mentioned in one of the sperm.
Yes. No, immortality doesn't matter. The testicular sperms may be immortile. It is the motility gains after that, so it will be immortal. So no matter. Only thing it has to have its viability. But we can't check the viability. Maybe we can do that horse test. What we do, we can hypoosmotic swelling test to check the viability and then inject that. So just we have to give a trial. So most of the sperms what we take from the test is it will be immortal. Ejaculated sperms will have a lot of motility. Okay. Yeah, sure. Yes.
What do you think would be the disadvantages in automation of IVF plans? And
Job. Our job is very important. Your job is very important. She's an embryology trainee here.
disadvantages in the sense, how would the success rate be?
Because once we started doing only, then we know how it's going to work. Anyway, machine is machine. What happened yesterday, we know Microsoft crashed and everything they were getting, everything in all our boarding passes were written in letter. No? Yesterday the whole day Microsoft crashed and all flights were crashed. So it was a problem yesterday. So it can happen. So technical thing always there will be an issue. Always we have to believe our hands. Yes. Thank you.
So any more questions? So there are no more questions. I have a last question.
Yes.
Not a medical question.
Okay.
Social question. Your last first sentence was reading social freezing. The social question to you is okay. Mother, father, one child is nuclear family.
Yes.
Is it? If a girl is allowed to have a baby and she runs with that, what do you call that family?
Okay. Nuclear family, I don't know. Without a husband, that's what it is. Yeah, that's what it is. Without a husband, a girl, and it's a family, and we can cut the nuclear and just it's a family. They want a family. That's why they're coming for a child. So it's a family.
Thank you, madam. Very nice presentation.
Yes.
Thank you all for your
Thank you.